Alrighty, well, welcome back everybody to Ultrasound Grand Rounds this week. I'm pretty excited to be here this week. If you've noticed, there's a little bit different location maybe. I'm not sitting at my office. We're actually down here in the Sim Center down here at Metro. And we're gonna have a little bit different setup today because like I promised, today's topic is gonna be Diane's tips and tricks, but I'm not Diane. So I wanted to introduce you to someone who's been a fixture of our ultrasound division. She's been someone who's taught me most everything that I know about ultrasound. And she's been gracious to join us on the forum today to talk a little bit about ultrasound and not just, like here's how to do this study, but what are those little nuances that may be helpful as we try to understand kind of how to do these things that, take our ultrasound from maybe this level to this level. So with that said, welcome to Diane as to coming onto the forum, and I'm really excited to have you here. I know you're really excited to be with us as well, right?
Yes.
So before we get started, obviously we've talked about you on the forum a lot, right? And kind of your influence in our division, in our trainees, kind of shows up everywhere. And so everything we do kind of has your fingerprints on it. So I thought it'd be helpful if we maybe started off today by just kind of introducing you and kind of who you are and kind of how you got to where you are now and kind of what your pathway has been in ultrasound. So tell me a little about yourself. Like, how'd you get into ultrasound? How'd you get to where you are right now?
Well, I started out as an x-ray tech, and back in the days before they had ultrasound programs, you had to go through x-ray first. So once you went to x-ray, then you could branch off into different modalities like ultrasound, MRI, CT, and stuff. So once I finished the x-ray program, then I branched off into ultrasound, and then I came to a program here at MetroHealth, which they had the one-year ultrasound program, and then I graduated, and then I was very blessed and thankful to get a full-time job here. So I've been here since '93 doing ultrasound. So I lived down in radiology for the first 14 years, got all the comprehensive skills and everything down, and then I decided to make a change and come to the ED and be the educator down to the ED for POCUS ultrasound. So. And
when did you come to the ED for POCUS?
2007.
Perfect. Okay. So you've been with us for, man, my math on the fly is not as good as it is on paper, but it's been quite some time here. I think it's about almost 20 years that you've been with us in the ED, which means you've seen a number of classes of residents and fellows go through the ED, and you've been very influential in kind of shaping them. Besides myself, of course, is there any resident or fellow that sticks out to you as just kind of wow, this is really encouraging. Like I was able to take this person from this place and they shared with me an image sometime later, like that really made a difference and just kind of really got you fired up. Like, do you have those experiences?
Yes, there is a resident, Sarah, that went to Alaska, and she still every once in a while will send me a picture, de-identified of course, and will question or ask me something, and then I will communicate back to her and stuff. But has said that using ultrasound in Alaska has been very beneficial, being so remote and not having ultrasound techs all the time. So it's very helpful for her to have the skills that I planted the seeds to her, and now she's in Alaska doing these studies. And if she gets stumped, she can always call me, text me, send me pictures, whatever, and then I can help her. So the seeds are planted and they just kind of keep growing. So
yeah, and I remember Sarah was the fellow when I was an intern here, so we overlapped just ever so briefly. And I agree, Sarah was just a huge asset to our department for the time that she was here. So
also heard one from Washington, Spokane, Washington, Dan Haggerty.
Yeah.
Just got in touch with him, and he's using ultrasound all the time also. And so it's nice to know that the seeds been planted all over, not just Ohio, but they go through the fellowship, learn all the knowledge, and then they take it off, and then they start fellowships or use it in their practice.
And I think that's the cool thing as I think about medicine, whether you be clinical or academic, when you're clinical medicine, you're seeing the patient, you're having a direct impact one-on-one with that person. And when you're in academic medicine, you really come to the bedside, you come to the bedside, yes, but you also teach these people who then go to the bedside. And so there's an exponential multiplication of kind of that skill set that we try to teach and convey to all these trainees who then go out and impact, hundreds and thousands, if not hundreds of thousands of patients down the line. So that's pretty cool. Over nearly 20 years of practice, just the thousands of patients that your work here is impacted. So anyway, cool. So is there, tell us a little bit about what's the difference from your perspective? You were the bedside sonographer, right? Doing very much, here's the protocol, right? Now to a well, actually, I should say a radiology sonographer, now to a bedside sonographer. Like, what's the difference for you? I know for me, there's a little bit of a philosophy difference, but for you, like, how do you see that different?
Well, using the comprehensive skills that I have through radiology, when I do a POCUS scan, I know there's specific questions that you want answered. But having the comprehensive skills, when you're looking for that single one thing, you may catch other things in your peripheral vision that you weren't really looking for. And when you're trying to do a gallbladder on someone because you think there's stones and you don't see stones, but then you sweep lateral a bit and you catch that hydro on the right kidney, then it helps to have the comprehensive skills that you can kind of think what else could it be, and then you can kind of be the puzzle solver and stuff like that. So it kind of helps to have the extra skills, but then be able to hone it in and just get the answers you want for that one specific study.
Perfect. Well, let's switch to some ultrasound here. Okay. Diane has put together a tips and tricks, basically document, or I should say usually put together a document. And I was thumbing through it and I'm like, this would be perfect for a book, but it's not. It's a document that we have here. It's a resource for our people, right. With a ton of the amazing skills and the little nuances and the techniques that you've learned over the years that, I know that as I read through, I'm like, this is my fellowship in in a 20-page document or however long it is. We're just like, we're at the bedside kind of going through all those little subtle things. Like, here's how you, like, not just what you need to find, but here's how you need to find it and the best way to do that and optimize that. So I think I'd like to spend the rest of our time today talking about that and how we can kind of take that scan and level it up to just the next level. So I guess the first thing to talk about is, before we even get to the patient, I mean, ergonomics, positioning, scan, like that makes a huge difference in how you do the study. So what are some of the things that you've learned, you think of that, as you roll into the bed, or roll into the bedside, like that helps you out kind of making the study even better just from that perspective? Right.
So I always put the machine on the patient's right side of the bed. That's just like the standardized patient of doing it. So when you're scanning, you use your right hand to scan, you have your left hand to run the machine. You want to make sure the bed is at a height that you're not leaning down. So you can always pump the bed up so it gets more of a comfortable level, because you don't want to be down here cranking your wrists and stuff and trying to look at the image. So you want to make sure that your machine is set up properly and that you have the height at a proper level. That's the main thing, so that you're running the machine with this hand and you're scanning with this hand. Because sonographers don't have extra helpers that can run the buttons while you're trying to scan and go on this side and reach out. You don't have that as a sonographer. So you have to be able to run it with this and scan it with this. So we always do the patient's right side.
Gotcha. And so I know one thing that you've kind of harped on me a lot, kind of when I was training, and I see you kind of going through that with all of our residents and our trainees, is how do you position and hold a probe? So start with like the base hold for how you hold a probe.
So when you hold the probe, you want to hold it like it's a Sharpie, like the nice thick Sharpie. So the probes are actually ergonomically made so that your fingers can fit in there nicely. So you want to have the probe like you're going to write with it. You don't want to hold it like you're trying to beat something or you're scared to death of the patient. You want to hold it so that your fingers are like this and then your hands are on the patient. Because when your hands are on the patient and this part of your hand is here, you know how much pressure you're putting down too. You're not hurting the patient. So you want to get comfortable with that. That way you can turn your wrist, you can rock, you can tweak, you have much more fine motor skills when you do this method versus trying to do this, or this dreaded thing when you stick your palm up and you do this. You have no fine motor skills doing this. So you always want to have it, hold it like a pencil. It doesn't matter if you're doing the left side, it doesn't matter if you're doing the right side, it doesn't matter where you're going, your hand is still going to be writing. So you want to, that's the proper way to do it.
Let me see the probe here for a second. One of the things, I'm sure you taught me this, but this is one of the things that I teach with our residents when I'm on is, the next point of contact to the ground is your source of stability, right? So if I were to hold it like this, my the next point of contact with the ground is obviously the probe head and then my feet.
Right.
So that means the muscles that are needed to kind of provide stability and movement to this are everything from my toes up through my legs, my core, my shoulder, my arms, my forearm to provide stability for this. Right. Rather, if I were to take the same probe, right, hold it like you just described, and make the next point of contact the base of my hand, just like this. Now I've isolated all of the big muscles, like the shoulder, the core, the legs, And the only thing controlling this probe is those fine motor skills. And so it gives you a ton more control. And I think, it's one thing that as you're talking about like going backhand and going, these funny different like scared of the patient type style, like you lose all of that ability to control and you require so much more energy just to be able to do this. So and I think that's something that I've picked up kind of over the years as we've talked about this.
It's also good too when you're doing like procedures. If you're doing an IV or a central line and you have your hand on the patient, what happens is if someone comes in the room and tries to get your attention, you turn and you're holding the probe like this, you're going to move your hand. But if you have your hand planted on the patient when you turn, you're not going to lose your probe. Or if the patient moves the arm, if you're holding it, then you're not going to lose it, versus when the patient moves because it hurts. If you're floating, it's going to be off. So you always want to have your hand planted too, so that, especially with procedures, that's another.
Yeah, I mean, you get so much of that that visual or that tactile feedback just simply by having your hand kind of in contact with the patient. You can kind of feel the subtle movements of the patients and make that stable. I think that's a huge important point. So. So cool. So we talked about don't backhand it, don't dangle it, don't kind of like hammer grip it, Sharpie grip it. What about those couple windows where you can't? Like there's just your hand is in the way. Like is there a secondary move or hold?
You can roll the patient. You can have them roll up if you need to get there, or if, especially with the right side, you can't basically bring the arm above their head so you can get in there better, and then you just kind of, and you can also bring the bed up higher so you can do it a little bit easier. I think moving the patient around too will help you, especially on this side. If you can't reach more, have the patient roll up on their side a little bit so you can get back there. So positioning the patient, making sure your bed's high enough that you can do that. Those are helpful things.
Yeah, and I can't emphasize enough kind of what you said about just positioning the bed, right? I know a while back we did a lecture on the ergonomics of ultrasound. And this is one of the things we talked about. It's like, there's no sense in killing your back to get the study, right? The beds move, right? And we have chairs. So either bring the bed up or bring you down, but get yourself in the position of comfort, because when you're there, two things are going to happen, at least two things. Number one is you're going to get a better study, right? You're going to be able to see, get those, the images that you need and kind of do it better. Number two, you're not going to hurt yourself. In fact, I ran across, it was an abstract presented at a conference years ago about musculoskeletal injuries in point of care ultrasound people.
Shoulders.
And so a lot of these, like,
elbows.
If we're leaning over, like you're killing your back, if you do that year after year after year. So yeah, I think those are some of the things that you've kind of impressed on me, is like, just set yourself up for success and hold the probe the right way.
Correct.
Cool. So let's move on from ergonomics. Not everyone, everyone's like, okay, ergonomics, whatever. We're here. But let's start talking about some scanning, like, and some things that are helpful, particularly in the abdomen. Because I think that's where, there's challenges in all the different studies that we do, but the abdomen is particularly difficult because you're dealing with air and you're dealing with just tons of stuff. And so finding little structures, let's talk about that.
Okay.
So I think the most ubiquitous study, at least in my mind, is just the FAST exam. Maybe not be the one that we do the most, but it's just kind of, it's where point of care ultrasound got its roots, and kind of let's just go back to there, and it's something that we need to know about. So for those joining us, this is John. He's one of our residents. He's graciously donated his body to science today to help you guys learn how to do better ultrasound. So thanks, John, for being here. But yeah, if we talk about the FAST exam, we start, you do whatever quadrant makes sense clinically, but let's start in the right upper quadrant here. As we kind of think through the different windows. So tell me a little bit about the right upper quadrant. Like what are we running into? What are your priorities? Kind of what can we expect to see?
I think one controversy is always with which probe do you use for the FAST. You can use the curved or you can use the phase. You do not want to use a linear because a linear is too high of a frequency. But I have found over the years that if you use the smaller footprint, which is the phased, you can get between the ribs a lot better. And if you can't get that subxiphoid view, then you're going to have to go to the chest and do the parasternal long anyways, so you might as well just use the smaller probe. You can use the larger probe. You'll have a smoother look, but the problem is you'll run into the rib shadows a lot more with this one. So I have finally graduated over to the phase. I used to be a curved person, but now I'm a phase lover. But what you want to do is want to put some gel here. So the three windows for the FAST, you want to make sure you can see the diaphragm between the kidney and the liver, which is the Morrison's, and then the tip of the liver. So when I scan, I start quite high. People always think you're going to scan down low underneath the ribs, but I scan quite high. So you want to make sure your depth is accurate. So you're going to drop it down so you're not cutting off any liver here. So when I want to see the diaphragm, again, if you're not familiar with ultrasound, pretend this is a person here, head and then feet. So head, feet. So they're laying like this. So their head is this way and their feet's this way, anterior, posterior. So when I'm scanning this way, I'm going to see diaphragm here, lungs, and head's going to be this way. So when you're scanning, you want to see this nice bright echogenic line, which is the diaphragm. If John takes a deep breath in, you watch the diaphragm move down. That will also help you. And then you can see the lung jump in. Okay, breathe out.
Yes. Just so that we kind of remember some of the anatomy, the reason why the lung jumps in is because it's a dome, right? And so as we breathe, we're kind of flattening things out a little bit. We're also bringing that anterior tip of that lung down, and eventually it's going to kind of fall right underneath our probe and start blocking that view.
Take another breath in. Let's do it again. Okay, good. And then breathe out. And you can see how the lung comes in and the lung goes back out. So you can see the diaphragm nicely here. Then you want to look between the liver and the kidney. This is the Morrison's pouch. And then you just literally just slide down towards his toes to get the tip of the liver. You may need a little more gel here. So once you find your window, it's literally like zippering. I mean, you just zipper, you come up higher, diaphragm, Morrison's, and down to the tip, which is like right here. So a lot of people, when they do fast, they do that palm up and they think that they have to be knuckles to the bed on the right side. Sure, you can get the liver on this view, but look what you're doing with your hand. You have no fine motor skills. So I do not recommend this view. This is painful to even watch. But because the liver is such a large organ, yes, you can see the liver here. Yes, you can see the liver higher. Yes, you could see it higher. So there's no point in having to bury your knuckle to the bed on the right side because your liver is a nice organ, nice large organ that you can use. So you literally just here, there, and then slide down. It's real simple. There's nothing fancy. You have to go back and forth. You just zipper right on down. The other thing to remember too is if your ribs get in the way on your image, if you feel where the ribs are on a patient, it's literally like on an angle. Ribs aren't straight out. They're on an angle. So if you're getting ribs, just take the indicator of the probe and just go between the ribs. And then you'll get rid of the rib shadow. So if I'm on a rib shadow here, you're going to see just a dark shadow. You're not going to see anything. But if I go above and get between the ribs, then it works a lot better. See there how you got the rib and it's going right over the rib? So just fit between the ribs and then you'll get rid of that rib shadow. So I always say 10 o'clock position, we take the indicator towards 10 o'clock for the right side. And then on the left side, it's the opposite because the ribs are going this way on the left. So it's gonna be more like a 2 o'clock. So I always think 10 and 2, like old driving school stuff, 10 and 2. So 10 o'clock here, 2 o'clock there, and that'll get you in between the ribs a lot better than being straight on at 12 o'clock. On John, it works okay, but I still get a rib if I'm 12 o'clock versus when I go between the ribs, then I can get a nice, beautiful picture here without any interference from the ribs.
I think that's one of the keys. Like it's not oftentimes mentioned either in videos or in textbooks, about how to like improve it and get rid of those ribs. It's just like, oh, you know what, put it in the right upper quadrant and you'll find this Morrison's pouch and look for fluid in the Morrison's pouch. Like that's where the teaching goes. But then to have that, hey, we got this stuff that we're going to run into, especially if you're coming up onto that chest, right? Twist towards 10 o'clock to get those ribs out of the way. And that, okay, maybe you're not completely on the long axis of the kidney, but who really cares? We're looking at that space, we're kind of fanning through it, but now we have a beautiful window looking through those ribs.
Correct.
So that's perfect. Now, a couple things that I've come across over the years, I know you and I have talked about it, is sometimes, it's depending on the machine, there's a little thin black stripe of fluid underneath the caudal tip of the liver. That's artifact, and that's not referring to like any fluid. Correct. So how do we like deal with that? How do we kind of either get rid of that or convince ourselves that that's not free fluid and that's actually artifact?
You can try Harmonics. That's Bob's trick. You can try Harmonics, or you can just try a different window and different angle. See how here you get that little black fake line? Or you can try taking it off. Either way, it's going to still kind of be there. So I kind of slide around, do little different angles like that. So I just kind of slide around an angle a little differently to get rid of that little fake black looking fluid fake kind of line.
And the theory with that one is that if it's true free fluid, you'll see it in multiple different angles.
Try different windows, try different angles to try to get rid of that. You can do the Harmonics. Okay.
And the other question was, and this is obviously not John's issue, because we're seeing a really nice bright line that represents the interface between the liver and the kidney. But you know, a lot of the patients that we scan maybe have extra adipose tissue, both you know, around them and then inside them, right? So I guess we can take both of them, but let's do the inside first. Perinephric fat, right? That's a place that you can deposit some fat kind of around that kidney, and it can be something that is a little bit confusing if you're trying to interpret, at least in the heat of the moment, like how do I know that this is not free, like clotted fluid? How do I know this is perinephric fat? So what do you use as kind of ways to kind of differentiate that?
So usually the kidney kind of butts up against the liver, just like John's here. But if they have that perinephric fat, there's going to be a gap between the liver and the kidney. And it's like a band, and it's a little more hyperechoic. And you'll see like little, almost like striations through there. And when you scan down towards the tip, you're going to see it continue down. So you know that that's not fluid. And if it was like clotted blood, then you would see more sloshing kind of a motion because it's fluid. It's not a fixed perinephric fat. So you just want to keep an eye on that. And if you see it on the right side, you're most likely going to see it on the left side because it's going to be kind of paired. So don't get that confused with clotted blood. He obviously doesn't have any perinephric fat, but it'd be a nice little band. It would be like separating the liver from the kidney. And you see like this gap, like this little more hyperechoic band. Sure. And then would kind of go down towards the tip of the liver here inferiorly. And it would look very consistent.
And what about that scenario we talked about? So we have the two scenarios, the internal fat, the external, you know, adipose tissue. Because one of the things I found, because you told me about it, is that adipose tissue in and of itself is very sound attenuating, right? The sound just gets stuck in there and doesn't come back, which means it makes everything else deep down to it very just kind of fuzzy and kind of that, you know, static-y picture from like old school TVs. So like, how do we deal with, you know, with getting through to that and kind of getting some deeper images when we have a lot of, you know, abdominal fat?
Right. Well, there's a button on the machine called frequency. So it's got an R, a G, and a P. So you have resolution, general, and penetration. So when you select your preset, which is fast, it's going to give you a higher frequency automatically. So then if you need more frequency, you can manually lower the frequency by just hitting the frequency button. And now it's going to go down to the P, which is penetration. So it's going to give you more punch power. You're going to be able to see a little deeper. And you can also adjust your positioning. If the patient is really heavy, try to go in between like a fat roll kind of to get closer to the liver. But the first thing I would try is hitting the frequency button. You can see this is resolution. See how fuzzy it is? It is too high. And then you got your general. And then you have your penetration. It gives you more punch power. You'll be able to see the deeper part of the liver better. And that's where I would start there.
So let's move on over to the left side, right?
Okay.
Because it, you know, pretty much hits the right side. Left spleen obviously is there. It tends to be a little smaller, which means the liver tends to, or not the liver, the kidney tends to live just a touch higher. And I've seen a lot of people struggle, myself included, with like, I just can't get that window because you're stuck between like, there's bowel on the low side, there's lung on the high side, there's ribs in the front, and then it's like, where is this thing? I get maybe like a whiff of the kidney and that's it. So help me out with the spleen.
So again, hold it like you're going to write with it. You're going to come around here and it's like an ice cream scoop. I put my knuckles towards the bed and I scoop way back here. So you got to do a little bit of a leaning and you're going to reach back and you're going to see the spleen here. So here's your spleen and here's your kidney. So if you slide up higher, see this little fuzziness? That's your lung sliding in. So if he takes a big breath in, watch how the lung takes over and it's like a curtain, like shows over. You don't see anything. When he breathes out, now the lung is going to slide back up and now you're going to see your spleen here in a second once. There you go. So when you're scanning, if he can take a breath, then you do not want to do a big breath on the left. You want to do a small breath. The costophrenic angle of that lung is going to slip down and cover you up. If you think of a chest x-ray, how the costophrenic angle comes down, that is going to get in your way. So if anything, do a small breath, think small spleen, small breath on the left. But the right side with the liver being so much bigger, you can do a large breath on the right and then a small breath on the left. So you want to, the hard part is getting the diaphragm on the left. So I always say for females, it's like bra strap level. So you don't want to be down here by the hip bone. You want to be nice and high. Go up towards that armpit. And then you may have to go back to the bed. Or if you can't get back there, which works beautifully for John, but you can also come a little more anterior and do a steep angle over the rib if you have to, like this. You can come back and kind of sneak way back. So it's all about working with the ribs. And if they can raise their arm above their head and that will open up the ribs also. So those are some tips and tricks. And you don't want to get this confused also. See this little black structure? Go ahead and breathe out normal. There you go. This is actually a vessel. That's in the splenic hilum. So you don't want to get that confused with free fluid. Because when people see something black, they think it's fluid. It is, but it's in a vessel. So if you're unsure, just put the color on there and you'll see that lights up like a Christmas tree, and that is just a vessel. That is not free fluid. And if I'm seeing just this and I don't see the kidney, I need to fan my probe down to the bed to get that kidney in there. Mm-hmm. John was gracious enough not to eat, but if he had a full stomach, when I scoop up towards the ceiling, more anterior, I'm going to see a full stomach. This is where your stomach would be. And if there was fluid in there, you would see just fluid, but it's contained. So if you're seeing stomach and not kidney, you want to fan down to the bed because your kidneys live more posterior. So here's your fanning down versus your fanning up and getting in the stomach area. And if they drink a lot of fluid, you're going to see a big old bolus of fluid there, but it's contained, it's in the stomach. So you just kind of fan down and then just kind of play with those ribs there.
Yeah, I think that's one of the important things to keep in mind about the left upper quadrant is that you have that fluid-filled structure adjacent to it. And so as we're scanning, you can't just like scan past like, oh my goodness, there's black, like it must be free fluid.
Right.
If it's in the place where you'd expect the stomach to be, scooping up and seeing that, especially that well-bounded fluid collection, then that's stomach, right? And then also we know like the free fluid's going to live above the spleen below the diaphragm, typically in the left upper quadrant. So a couple of things to help out there. And one of the things I know for me, when I was early on in my ultrasound journey, I guess as it were, particularly up in this quadrant, I'd scan and all I'd see is air and get super frustrated. Like, this is ridiculously painful. Like, I can't get around this air, until I had this realization that it's like, air is coming from somewhere, right? Mm-hmm. And when I'm here, it's coming from the lung, right? And so when I started getting comfortable with the fact that I couldn't see meant I actually could see something else, right? I could see that lung. And then now it's like, okay, I see air, I know where I am, as opposed to I can't see anything, I have no clue where I am.
Right.
And then I can adjust my landmarks from there. It's like, oh, well, if I'm seeing air, I'm too high, right? Come on down and kind of angle back up. And now, like, I can actually see. So getting comfortable with that blindness, as it were, was really helpful, kind of getting that orientation.
Right. And if you find your left kidney, then that's going to guide you, because you got to go more superior. You got to go slide up to get the spleen. So if you find your kidney, you're too low. If you find too much lung or air, you're too high. Then you have to find that happy medium. Yeah. That's one of the things I like to teach is just find the landmarks. Right. And like we've all done anatomy, right? We know the gross landmarks, at least where the lung is compared to the kidney, compared to the spleen, and then kind of walk things around from there and kind of figure stuff out. Right. So cool. And you said 2 o'clock, twist towards 2 o'clock to get through those ribs. Correct. And small breath to get the spleen visible. Right. So with that said, I think I'm going to cover the left and right upper quadrants. Let's pop down to the bladder and talk about a few things, because this can be particularly difficult, particularly if whoever we're scanning has recently used the restroom. Which I think that's John. Thank you for making it... giving us something to talk about here. So remember, the bladder lives very, very low. You want to aim towards the pubic bone. So if you're not sure how full the bladder is, I would start transverse and go all the way down. So the goal is to find the pubic bone. Actually, his bladder is right there, so I need to go. So let me change the depth and make it a little bit easier. Sorry, John. I don't mean to be so low. But you want to find the pubic bone, which is the bright echogenic lines there. And then when you sweep superior, you're going to fall into the bladder here. So his bladder is very small. And I'm just going to do this. So now you see this is the bladder, and you can see the wall is a little bit thicker because it's empty. So once you find your bladder, now you can spin the probe towards sagittal, and you can see the bladder wall around there. So you're at the bladder. And then if I angle down more, you get the pubic bone. It's a bit a funky angle, sorry. But you would use the pubic bone basically as a landmark. And you can see the prostate back here and the seminal vesicles. And you don't want to confuse the seminal vesicles for free fluid, because the bladder is here. There's going to be no free fluid inferior anatomically. It's not possible. So it's going to be here and superior. So for a male, you're going to see bowel. So I would sweep or fan all the way to the side, both quadrants, basically, looking for any little pockets of triangles of fluid. So I don't see any here. So if you go all the way out and you see the iliacs, you've gone out too far. There's your iliacs. And then you could sweep more midline. Now, if John had a uterus, you would see the uterus coming more up here. And where some of the vesicles would live would be the vaginal canal. So it's the same thing. You're not going to see any free fluid for the vaginal canal inferior. Everything's going to be here over superiorly. So if the uterus was sitting here, you would look for free fluid behind the uterus in the posterior cul-de-sac. Or if there's a lot of fluid, it can track down between the uterus. This is a uterus. It would track between the uterus and the bladder. So these are the kind of the areas you'd look for a female, versus for a male, it would just be basically from here over, from the bladder over. And bowel should be the only thing living in a male. So that's what you want to look for.
And I think that was helpful for me when I was early on when I was learning, is just kind of, again, thinking through the anatomy and like, okay, where would I expect to see free fluid? Because my first thought after like kind of the first round of just learning how the fasting works is like, I put the probe down and it could be anywhere, you know, but then realizing like, no, if I'm looking for intraperitoneal free fluid, it's going to be within the peritoneal cavity, which in this sagittally oriented bladder view, it's going to be coming on the underside of the anterior abdominal wall, looping over the top of the bladder, and then kind of going up kind of on the anterior surface of like that rectum and kind of the posterior part of the wall. So like everything on the right-hand side of the screen is pelvic. Doesn't mean you can't have fluid there.
So here over is nothing.
But it's not intra-abdominal fluid versus on the other side is the intra-abdominal fluid. So I think that's helpful. And then, like you said, that idea of like orienting to known fixed structures, right? And using that pubic symphysis is the key. So like in sagittal, looking for that bony knuckle to the right-hand side of the screen. Yeah. And then whenever I look at it, probably just because my last name starts with a T, I always see a T in the transverse side when you have like the two sides coming together and you get that little pubic symphysis gap there. So. And the bladder's just immediately right above that. So understanding those two things has been hugely helpful in leveling up my game. So.
And you don't want to confuse ovarian cysts on females. Yeah. You don't want to confuse the fibroid uterus or the uterus in general, because when people can't find the bladder, they automatically look for something round, which could be a cyst, could be bladder, could be prostate, could be, they're like searching for anything round to measure. So you want to make sure you find the pubic bone, slide up just superiorly, just a smidge, and you'll fall into the bladder. Yeah,
I don't remember if I posted the video of this or just done a lecture here. But I know we've talked about kind of those bladder mishaps.
Yes.
So some of the ones that we've seen is like the cysts, loops of bowel. Yes. What else have we seen that
uteruses, fibroid uterus.
Yeah, things that are dark in there.
Yeah, they see something dark and they get confused.
Cool. So the 3 windows. What order? Like a lot of people when I talk to them, they're like, how should I protocol this? Because everyone loves to kind of that, like, tell me step 1, step 2, step 3, and I'll just check it off on my to-do list. Like, what order do we do?
So what I try to do is I look for the injury. If the patient was stabbed in the chest, shot in the chest, something chest-wise, then they're probably going to want lungs first. So I would probably just change my probe and do lungs first. If the stabbing is in the upper abdomen, or if the stabbing, so you want to kind of see where the injury is and then find out what's going to happen next. If they're prepping over there to do a chest tube on the left, you're going to want to sneak in there and get your left upper quadrant shot before they start slapping that betadine on there where you can't get in there. If the patient has a pelvic fracture and you're trying to bind the pelvis, get in before they do the binding. Or if they're doing a Foley catheter, you want to get in there before they do the Foley, because then you lose your bladder window. So kind of keep an eye in the room, what's going to happen next. And if there's no procedures, kind of go by the injury. If it's higher up, scan up higher, right upper quadrant. Maybe I usually do right and left. But if it's a lower pelvic fracture or some kind of injury to the lower pelvis, then I would do the pelvis first. So I kind of go by the injury and what procedures are going to be happening next. So I kind of tailor it to what I need.
So it requires a very well-developed sense of situational awareness, to understand kind of what's going on with the patient, what are the clinical priorities, and how can we use this to augment that decision-making in the least obtrusive manner possible, and get the stuff that we need, the information that we need before that information is then gone because we did something else, like introduce air or something like that. So what about the scenario, maybe we'll kind of wrap things up with this, the scenario where we need to get the study and you have a very, very antsy, we're going to pick on trauma because they're not here right now to defend themselves. But very, very antsy trauma surgeon looking over your shoulder, like, I need to get in, I need you to get out. Like, how can I just get that image quickly and then maybe review that, but also be efficient and quick about it?
So you can change the loop time on the machines. So if you hit on the Spark, there's a little middle button here, and this will change my loop time. So if I increase my loop time to like 7, 8, 9 seconds, when I'm scanning, I can just hit the acquire button and I'll do a lot of video clips. That way I can just get in, do my quick scan, not have to freeze, label, do all that kind of stuff. I can just do the video clip by hitting acquire, take my quick clips, and then I'm done and I can get out and then let them do their job. And then when I'm out in the hall, when things calm down, I can go through the video clips and actually freeze my images where I want, and then I can label them and make the pictures pretty.
Yeah.
But I just need to get the images, so I do longer clips. So I just change the loop time on the Spark, and that'll give me like a longer clip, but I have more time and I can acquire more images from the clips.
Sure. And one of Matt's tricks and tips to dovetail on that one is there's been some literature that basically says when we do ultrasound, particularly with pulse checks and CPR, that we delay the restarting of CPR, right? I think it was 13 seconds without ultrasound and 21 seconds with ultrasound. When you're shooting for an ideal of, I think, 10 to 15 seconds off chest, closer to 10 is better, right? So one of the things that, I know you and I've talked about, we try to teach our residents is set that loop time for 10 seconds, right? As soon as they come off chest, scan, hit acquire, and as soon as that acquire is done, you're done. And it's your timer to get in and get out, and to let them get back on chest. But then you also have the added benefit of you saved that information and you can then kind of go back into the corner while CPR is happening and kind of scroll back through and look through and find the nuances and the subtleties of the study, at least for that particular clip. So
and you can compare the clips as the code's going on. If
if
it's squeezing better and then not squeezing, you can at least show the time frames of the squeeze changing.
And then decide if this is physiologic tamponade or whatever the case may be. So, perfect. So we walked ourselves through the abdomen. I think we're probably gonna have to wrap things up here. Okay. But I think this is a ton of great tricks. I know a lot of these you've kind of taught me over the years and have just been hugely impactful in the way I care for patients, and I think are going to be very beneficial for the people who are watching. Both now and then, kind of on the YouTube channel, as they then take these tricks and go to their respective places and start implementing them and caring for patients. So thanks for coming on. Thanks for being part of this forum, both kind of in the background, teaching us all the stuff, but then now kind of up front and kind of actually showing us how it works. So
you're welcome.
We'll look forward to having you back sometime and do some more of these.